Thanks for joining us for another installment of Clinician's Brief, the podcast, the conversations behind the content. I'm your host, Dr. Alyssa Watson, and our topic of discussion today is a condition that many general practitioners encounter quite frequently, recurrent anal sac disease. Specifically, we're going to be talking about a case of anal sac abscess in a dog with suspected adverse food reaction. Our guest today is veterinary dermatologist and associate professor at The Ohio State University, Dr. Sandra Diaz. You at home can find the article that inspired today's discussion in the January 2023 edition of Clinician's Brief. Hi, Dr. Diaz. Thanks so much for joining us today.
Hi, Lisa. Thank you so much for having me.
Yeah, we're so excited. Before we jump into this case, I would love it if you could just introduce yourself to the audience. Let us know how you got to The Ohio State.
Yes, so I am from Chile. So I went to vet school there, and there was actually a professor from the Ohio State giving a lecture in Chile when I was finishing vet school. And I got so inspired, and I wanted to be just like him. And so it was a long road, but here I am at the Ohio State practicing my dream veterinary dermatology. So yes, it was a long road, but a happy one.
That is wonderful. I always had a special place in my heart for dermatology too. One of my professors was my absolute favorite professor, Dr. Jim Noxon at Iowa State University, and just instilled a love of the specialty, I think, into all of his students. So I'm excited for today's conversation. Honestly, I will tell you, anal sac disease is one of those conditions that, like, once I got into practice, I feel like I see it all the time, every day. And yet, I'm not sure I got a lot of guidance on, really how to address, especially these cases that keep coming back over and over and over again, diving into really deep down diagnostics and trying to prevent the recurrence in some of these. So if we could, I would love it if you would give, your opinion from from the standpoint of a dermatologist about when we first see these cases. When we have non-neoplastic anal sac disease specifically, how do those usually present?
Mhm. Yes, you're absolutely right, Elisa. It's a relatively common complaint for small animal practitioners, and it's a topic that's definitely neglected. And I thought about it, and I think it's because it's often multifactorial. So they may present with perianal pruritus, so they will come to us, or they may be chronic diarrhea cases that may go to internal medicine. So I think it does have a hard time finding a home. And but as we work on more integrated curriculums, I think it's gonna be easier to address these problems that are relatively common, but then they're difficult to place, right? So do they go to dermatology? Do they go to internal medicine? Does a surgeon need to address this when there are more chronic problems? So I think that's usually what happens, and they get completely neglected. You're absolutely right. And then how do they present? So for us as dermatologists, the most common complaint is usually perianal pruritus, perianal discomfort, scooting, right? The clients notice that at home. They may have tenesmus, they may have dyschezia. So those are the most common complaints. But perianal clients sometimes they don't really pinpoint what it is, right? Is it pain? Is it pruritus? Maybe a little bit of both, but perianal discomfort is probably the most common complaint.
Is there a way to easily distinguish, anal sac disease from other conditions like perianal fistula when you first examine them?
Yeah, that's a very good question, and I feel like some cases with perianal abscesses that may fistulate, sometimes they are misdiagnosed as perianal fistula. So that's a very good question. So I feel like perianal fistulas, they usually have a strong breed predilection for German Shepherd dogs. So I always, when it's not a German Shepherd dog, then I will first work up Anal Sac disease. So I think that's kind of my role. So if it's a German Shepherd dog, then with very classical perianal fistula, that's likely what it is. But if it's a different breed, then I'm a little bit reluctant to jump into like perianal fistula. So I always make sure that I evaluate the Anal Sac before making a final diagnosis.
Yeah, I'm glad that you brought that up because that was actually kind of my next question was, are there breed or sex predilections for anal sac disease? And
Mhm.
definitely same with me. German Shepherd perianal fistula is going to jump like to the top of my differential list right away just from reading that in the history. So,
Absolutely. So, it's this the breed predilection is very interesting. So you find in textbooks and most reports that German Shepherd dog may be predisposed to anal sac disease. Also, Labrador retrievers are often mentioned. But there was this more recent study from the UK. They actually survey a large number of practice in regarding patients with anal sac disease, recurrent anal sac disease, and they found that Cavaliers, Cockapoos, we have all these new breeds now, right?
mhm,
Bichons, Shih Tzus were definitely overrepresented. And brachycephalic dogs have higher odds for anal sac disease. And what was really interesting to me is that actually both German Shepherds and Labradors have lower odds in
hmm,
their studies. So that was an interesting finding. And I wonder if there are like regional differences, right, with genetics, with popularity of certain breeds. But
certainly.
um, definitely we see small breeds, I feel, being predisposed, particularly Chihuahuas, right? I feel like we see more often in this breed. And the case was
Mhm.
actually a little Chihuahua affected with recurrent anal sac disease.
Yeah, I practice in Las Vegas, and we have a lot of Chihuahuas, and absolutely, I certainly feel just anecdotally that I see recurrent anal sac disease much more frequently in toy breed dogs and small breed dogs. Um, so, how does that presentation, or how do these dogs usually present any differently than animals with anal sac tumors, or are they different?
Yes and no. So the initial presentation may be very similar, right? So anal sac adenocarcinomas are at the same place where a normal anal sac will be. So the initial presentation may be very similar. They may have swelling at the perianal area, they may have discomfort, they may be scooting, they may be painful. So most anal sac adenocarcinomas are unilateral. So if the mass is large, they may have misshapen stools. So that may be something different that will kind of like, warn us that it may be something different. Also, there's a percentage of dogs with anal sac adenocarcinoma that will have paraneoplastic hypercalcemia.
Hmm.
And then those cases will likely have systemic clinical signs like anorexia, polydipsia, polyuria. They may be weak, they may be lethargic. So those will be a little bit different, but not all animals with anal sac adenocarcinomas present with those symptoms. So if they do, then it should be a warning sign for us to investigate a little bit more. And although they are in most cases unilateral, they may be bilateral. So very important for us to evaluate both. And also very important, sometimes we, especially me as a dermatologist, so our students are really good. So they often will include a rectal examination in their general physical exam. So interestingly, like up to 40% of the cases of anal sac adenocarcinomas are actually incidental findings.
Hmm.
So very important for us to not forget evaluating and performing that rectal examination.
Yeah, that rectal examination is a really important part of the exam. So if you can get it done and it's not too stressful on your patient, definitely something to be doing as often as we can. I know I've found them previously with, yeah, just incidental finding on palpating the rectal sacs. So um, I have heard differing opinions from dermatologists and from internists on the benefit to cytology of anal gland secretions. So, what is your opinion on the benefit of cytology or even culture when we're talking about aspirating anal gland secretions?
Yeah, that's also a very good question, Alyssa. It's controversial, as you say. There are different opinions. There was really nice study actually done, published in Veterinary Dermatologist, and they found that there wasn't. It was so variable. There was so much individual variation that is really difficult to pinpoint what is normal, what is abnormal. In that particular study, they included dogs with allergies and allergic dogs with pyoderma, and those dogs were found to have a higher number of cocci bacteria in their anal sac content, but not necessarily associated with clinical disease. So, at least their conclusion was that cytology may not be really helpful. So for me, it's so variable, right? The content itself, right? We can all agree that it doesn't smell pleasant, but other than that, it's very inconsistent, right? The consistency, it can be watery, it can be more paste-like, it may be chunky. The color can vary from brownish to grayish, and so it's difficult for me. The only thing that I will always consider abnormal is the presence of blood. So if there's blood in the content, then I would like to investigate a little more. And if you see abnormal, again, what is normal, what is abnormal is what is difficult to interpret. But again, if you do find blood, maybe it may be worth to do cytology, see if you have abnormal type of cells present in your cytology, investigate a little more the presence of different type of bacteria, white blood cells. That may help to guide your diagnosis, but unfortunately it will not be diagnostic during, due to the high variability that we
Mhm.
see.
Yeah, that's a really good tip, though, about the blood. Sometimes I also will, especially if we're seeing these cases back over and over and over again, I'll document, what's, you know, normal for that particular patient, because I think seeing changes over time can be really helpful, especially when we're on different therapies. You had kind of touched, and obviously we're going to talk a lot about food allergy when we get to this particular case, but you had touched on, these cases sometimes have underlying conditions. So, which metabolic and endocrine diseases can be associated with anal gland disease?
Mm, yeah, that's an interesting question. And, unfortunately, the cause is unknown, right? So it's, again, I feel like it's often multifactorial, but there are problems that have definitely been associated with recurrent anal sac disease. So, like soft stools, right? Or obesity, muscle weakness. So those things are problems that are associated with recurrent anal sac disease. So if we have conditions that present with those problems, like IBD or hypothyroidism, then those animals may be predisposed to develop anal sac disease. So we definitely need to recognize them and address them to prevent reoccurrence.
And when you're having a patient that is presenting for recurrent anal sac disease, what is your kind of minimum database? Should we be doing, for instance, a T4 on all of these patients?
Yeah, that's a good question. So I feel that it vary a little bit, and the cases that present to me may be different than the ones that will present to a general practitioner. But I feel like both the diagnosis and management is like twofold, right? So first, to address the anal sac problem, saculitis or impaction or abscess, and then simultaneously try to identify what is predisposing those patients to reoccur. So I it will depend a little bit of what other comorbidities or other presenting complaints may be, right? So, for example, if they have soft stools and perianal pruritus, I would likely, as a dermatologist, think of food allergies and start a food elimination trial. But an internist may want to work at IBD first, or pancreas insufficiency, B12, and things that internists do. So a little bit depending on, I feel like the presenting clinical signs. So evaluating the patient as a whole will be really important. So twofold, and not just focus on the anal sac disease, but what may be predisposing this patient to develop that problem.
So when you are going to start that hypoallergenic diet, that's one thing that again I see a lot of different personal preference for. Do you prefer limit ingredient diets to hydrolyzed diets, or how do you go about choosing that when you're putting these animals on a diet trial?
That's a freaking question. That's a very good question. So actually, a food elimination trial is such a simple concept, right? Change the food, don't feed anything else. But it's so hard to implement. Starting with the food selection, and I feel like fortunately or unfortunately, there are so many diets available over the counter now. I remember years ago a lamb and rice diet will be hypoallergenic, right? Because it was very uncommon. But now people can have such a variety of meat sources, and they often suspect that their animals may be food allergic. So they switch diets, and when they actually come to us, they have tried several diets. And so it's very challenging because of that. And also, the inability of performing a good dietary history in most cases. So most cases people do not know, or the pet have been recently adopted, right? We have a 5-year-old dog that with not known previous history. So I feel like it's challenging. I always ask my students, how long do you take taking a dietary history? They're like, 5 minutes. And how long do you think a nutritionist take? I work with nutritionists, so they're like, half an hour. I haven't seen them taking an hour. And
Wow.
to be able to collect all the information they need. So I definitely don't think I do a good job in my 5 minute dietary
Mhm.
history. So for all those reasons, I often do prefer an hydrolyzed diet.
Sure. Sure. You can kind of not have to worry then as much about what they've been exposed to in the past. So
Yeah.
the other thing too that I noticed about this case was that you had done a diet trial in this case, and the dog responded really well, and then the clients chose not to challenge their dog, which I find all the time. That yeah, we get onto a good diet, and we say, okay, now to truly diagnose food allergy, we need to go off of this or go back onto the old food. And everybody says, no, I'm not going to do that. But in the cases where someone does want to conduct a food challenge, can you just run through quickly how you do that? For instance, do you just feed them their previous diet, or do you actually challenge them with single ingredients?
Yeah. Absolutely, that's a good point. And most clients don't want to, right? Their dogs are doing so well, so they don't want to change anything. They have taken time for them to get there. But when we do, I actually offer them options, so they are more willing to do the challenge. So I offer them to either go back to the previous diet and then evaluate, or they can do a sequential challenge. So what we say is like, go back. Maybe most clients, you're not gonna believe, but most clients want to start with their favorite treats. I just like, when can I introduce again, those cookies, or and so that's what they want to restart. So we say, okay, fine, just start with that one thing at a time, and then if they have pruritus somewhere else, so if they have perianal pruritus, it's a little bit easier to monitor. If recurrent anal sac disease is the only clinical signs, then you may need a little bit longer time to evaluate, right? So it becomes a little bit more challenging. So if we know the frequency, if we know that this patient will develop anal sac disease every 4 weeks, then we know that we need to go a little bit longer to know if that particular allergen will trigger their anal sac disease. But if they do, if you have other clinical signs to monitor, like pruritus in other places, then it may be faster. So studies have shown that most animals actually will react within the first 48 hours. So we
Wow.
don't need to go that long. But when it's just that particular problem, then if you know the frequency, we may need to go a little bit beyond that. So that becomes a little bit challenging. But most clients, if they do want to challenge, what they want is to identify what may be triggering their animal's problems. So with the sequential challenge, although it takes longer, we're more likely to do that. If we start with the previous ingredients, then I go back to a previous diet and identify the main protein, let's say chicken, and I ask them to just boil chicken and just introduce that boiled chicken to the diet that we're using. So it takes a little time, but I feel like clients feel a little bit better because at least it's giving them an immediate answer rather than just going back to the previous diet and then any of the ingredients on that diet may be triggering their allergies. So I work with them, whatever makes them feel more comfortable.
Oh, that's wonderful insight. Thank you. Looking for that special clinician or veterinary nurse to fill your job opening? Job seekers from all areas of veterinary medicine can meet their ideal match on the Clinician's Brief Career Center. It's the best place to post your unique job opening and know it will be seen by that special someone. Get started at cliniciansbrief.com/career-center. So let's talk a little bit more about treatment of anal sac disease. Certainly this condition is associated with a ton of inflammation. How do you really decide when you're going to be using steroids versus when you're going to be using things like nonsteroidal anti-inflammatories like you did in this case for treating the inflammation that's associated with anal sac disease?
Mhm. Yes, that again, like it's case by case, right? So in this particular case, this little Chihuahua, she did have a little bit of facial pruritus. It wasn't present. I don't remember. I don't think it was present at this time of presentation, but the main complaint was the pain. So she actually did have an abscess, so it was very painful. And so non-steroidals were used in that particular case. But in cases of impaction, anasaculitis, and if they do have other clinical signs associated, right? Allergic dogs often have anal sac disease, then maybe corticosteroids will be indicated in those cases. There was a study done, a retrospective study recently that shows that ointments containing corticosteroid were very effective. So we may not need systemic therapy. We may just need, in most cases, just topical therapy,
Hmm.
which minimize side effects. So always considering, right, is there are there other clinical signs that we would like to control, the pain management, if you have a significant infection, are you worried about using systemic corticosteroids? Will a topical therapy be sufficient? So all those factors we need to consider when deciding which type of therapy to implement.
Sure. And when you're using those topical steroids, this is something that, oftentimes patients will come in, they're already on nonsteroidals for a different condition, for their osteoarthritis pain or something like that. Do you ever have concerns about using the topical corticosteroids for infusion in those cases? Is there enough systemic absorption that it's something we need to be worried about, or is it okay to mix those?
Yeah, that's also a very good question, and oof, that's a hard question to answer. I feel like in most cases, there's definitely some systemic absorption. We always balance the benefit, right? We like with any treatment, we need to balance the benefit with the risk. In general, with topical corticosteroid, in particular with some corticosteroid like mometasone that are not significantly absorbed through the skin, the systemic absorption can be minimal. So I feel like in most cases, the benefit versus the risk will be higher. So I feel like in most cases I won't be too concerned um, about using topical corticosteroids. But I always consult, like, we always have um, whoever had prescribed the non-steroidals and make sure that we know that that patient is a good candidate for the topical corticosteroids.
Perfect. Yeah. And probably a good place to just again be focusing on client communication and documenting that we've, talked about these potential risks even if they are unlikely.
Absolutely.
Yeah. Let's talk a little bit about oral antibiotics. This is a place where oftentimes I'm not sure like when to step in and use oral antibiotics because I know that oftentimes penetration into the tissue can be poor. So what criteria do you use for giving oral antibiotics for these cases?
Yes, and not only penetration but good antibiotic stewardship, right? We see so many resistant infections. So honestly, for most skin conditions, if possible, we like to treat them with topical therapy to minimize the exposure to systemic antibiotics. So that's a very good point. I use systemic antibiotics when they have abscesses with cellulitis. So if there's cellulitis associated with the anal sac abscesses, then I do use systemic therapy. But for most cases, and again, that the study that have been recently published, they have very good success in most of the cases with anal sacculitis with just topical antimicrobials. So I would say if it's not a complicated case, if there's no cellulitis present, then I will start with topical therapy.
Could you just walk us through how to cannulate and flush the gland?
Mhm.
Because this is another thing too, where I feel like people have different techniques. If the gland is already fistulated, some people will go straight through the fistula as opposed to going through the duct. So any pointers there would be really appreciated.
Yes, and that that's a very good question too. When they are a little bit more involved, if there's an anal sac abscess, I often consult with our surgeons. They do an excellent job with wound management, so they know all these little tricks. But in general, if there's fistulation, I will still cannulate the dog. So just to make sure that it's open, and because that may be a reason for reoccurrence. So I usually flash both. I often use a 5 French catheter. Um, to do that is what we use in the ear canals, is what we have easily available in the clinic. And just I use just saline. I'm usually worried, the skin is so inflamed, so I don't know how they may react to any topical antiseptic. So I just flash very abundantly with just saline until the eye is clean. That's what I usually do. But I know people do have different tricks and little things, but um, that's what I usually do. It's also a very important time to evaluate. I feel like these recurrent cases, and that's why sometimes I consult with our surgeons. I have the advantage that I have our surgeons next door to evaluate the presence of fibrosis. So if we have fibrotic tissue on the anal sac duct, and then if it's closed and we cannot flush them easily, that may be a case in which surgery may be indicated. So it's a good time to evaluate, especially if they have been a recurrent case. Will this patient actually benefit from surgery? Which I don't like when they get to that point. It's like Tika surgery, right? I feel like I failed them a little bit when they do need surgery, but unfortunately, some patients will benefit from it.
What kind of medications are you using for pain relief and sedation when you're doing those procedures?
Mhm. So we usually use, if not contraindicated, in most cases we use dexmedetomidine and butorphanol. Um, and then again, if I am like spoiled and lucky, I guess, because if there's a little bit more complicated, if there are comorbidities, I will have my anesthesiologist involved and have them just sleep for me to do what I need to do. So.
Mhm. Yep. No, that I mean, it's wonderful when you have those options available to you. So, kind of one of the other things I wanted to talk about as a general practitioner, a lot of times owners, make appointments to have the anal glands expressed, and they come in, they might not even see me. They come in, as a tech appointment. And sometimes I get to the case and I'm surprised to find out like they've been coming in every week to have anal glands expressed. So when we get to that point where we've really, addressed underlying conditions and things like that, how frequently should a patient come in to have their anal glands expressed? And if they're coming in too frequently, or what's too so frequent that it should be a tip off?
Yeah. Yeah, that's a good question. And again, there's like definitely varies from patient to patient, but I feel like it's often useful to think of those anal glands as part of the skin, right? And I do find, for example, in our cases, that if we have an allergic patient, if their allergies are flaring up, their anal glands are also need to be expressed more often. So I do feel like although it may not be obvious, probably their underlying condition is not well managed, and that's why they need such a frequent visit. So I always try to see what happened, why they may be flaring up. If they're food allergic, are they eating anything that they shouldn't be eating? If they have environmental allergies, is the pollen count really high? Is this dog having a flare? What is happening? So I feel like it's always kind of just think of the extension of the skin, part of the skin, right? So I do try to identify, or sometimes they may, if they're allergic, they just may need better control. It's really interesting. Sometimes the clients get used, I feel, to a certain level of itchiness that they may not consider abnormal.
Hmm.
Unfortunately, it's kind of sad in their patients with allergies. So there may be that constant inflammation that is triggering that reoccurrence. So I feel like I try to find a reason for it. But uh, for your question, like how frequently, I feel like it varies, but I think more than once a month is abnormal to me. I feel like it shouldn't be more than once a month. And in animals with allergies, when they flare, we definitely need to do it more often. My own dog, I do have an atopic dog. Of course, I do. And when his allergies are not well controlled, his anal glands definitely need to be expressed more
More
often.
frequently. Yeah. So that's a good, the once a month kind of general baseline rule.
I would say yes, or ideally less than that,
Yes.
right?
Yep. Yep. Um, so kind of just ending up on that surgery. I know that's not where we want to be able to control their disease before we get to that point where we do have to do surgery, but some patients, as you said, really need that for their comfort, and to help them. And so I know there are some complications of that disease, and I know this is the surgeon's kind of wheelhouse, but just briefly for people, what are things we need to be considering and telling clients about possible complications when we do need to move to an anal saculectomy?
Yeah, absolutely. So, although complications are not very common, they are scary, right? Because the anal sacs are associated with the anal sphincter, so they can have uh, problems with that. And, incontinence it doesn't sound very appealing for clients at all. So, it is unfortunately scary. Small dogs seems to be more predisposed to develop those complications, but even in small breeds they do seem to self-resolve,
Mhm.
so that's comforting that they don't happen very often, and if they do happen they may be temporary. So again, even with all that positive speech, clients get very concerned. Something to keep in mind is that if it's just one side affected, they usually don't develop fecal incontinence, even if the sphincters may be a little bit compromised. So the problem is more when both need to be done. What our surgeons usually do when I have discussed this with them is to do one, right, at the time, the most affected, and then if that will go well and they have good tone, then they will consider doing the other one. And so more risky, I guess, doing both at the same
Mhm.
time. So that's usually the things that I explain to the clients, and then they of course go to the surgeon and they will probably have more warnings and recommendations for them.
Yeah, that's really interesting. I hadn't ever really thought about staging those procedures, which is weird because I stage lots of other procedures, dental procedures and mastectomies and things like that. So that's a really good tip too. Um, so finally, what about histopathology? Do you feel strongly that if you're going to remove these glands, they should really be sent out for histopath?
I do. We know that chronic inflammation may lead to neoplastic transformation, right? So, and if they are to need surgery, they're likely very chronic cases with recurrence. So, I would say absolutely yes. I will submit those for histopathology. And that's a general rule. I feel like if you're removing any tissue, right, should go to a pathologist. So as a general rule, I would say yes.
Yeah, I think I've said that multiple times throughout my career. If it's worth taking off, it's worth finding out what it is, right?
Absolutely.
Yeah. So, okay. Well, we've kind of come to the end of our episode. And at the end, we do like to have a little fun. Okay. We've hit you with all these really important questions. And now I've got just a couple fun questions if you'd like to answer them.
Let's see.
Okay. Would you rather have somebody steal your favorite pen or somebody throw away the favorite blade you use for skin scrapings?
Oh, the pen.
The pen. Don't touch my skin scraping blade.
Oh, that's my.
Okay. Would you rather practice without topical steroids or without oral steroids?
Oh, you're killing me here.
They're mean, aren't they?
I would say, oof. Oh, that's a hard one to answer. I would rather live without oral corticosteroids.
Okay. Would you rather find out the puppy you were just snuggling is covered in scabies, or would you rather have a client want to show you their rash?
The puppy with scabies.
Okay. All right. Last question, okay? Would you rather have to do lime sulfur dips on 10 kitten-sized Tyrannosaurus rexes or 1 T-Rex-sized kitten?
Oh, that's a very good question. One.
1 giant T-Rex size, that would be a lot of lime sulfur.
Giant one. Yes.
Oh, that was so much fun. Thank you.
No,
Thanks for joining us for the podcast today. This has been really wonderful information. We truly appreciate you taking the time to share your knowledge with our audience today.
thank you so much. I enjoyed it.
Thank you for listening to today's episode. If you enjoyed our episode, you can find us wherever you listen to your favorite podcasts, including a video version now available on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@briefmedia.com. Clinicians Brief the Podcast is a Brief Media production, produced by Alexis, Ussery, and hosted by Dr. Alyssa Watson.